Good morning, Krishni. I can confirm that we are now live.
Thank you very much, Tom. Good morning, everybody. Welcome to our first meeting of 2024. I can see a very large screen of faces, so welcome to everybody. I particularly wanted to welcome Joe Ringshaw and Christine Price of Health Watch in Herefordshire and Worcestershire. We were keen to invite them to join us as participants as part of our commitment to hearing the public voice and patient voice, and so warm welcome to both of them. Also welcome to Rachel Hardy and Tracy Cotterill joining us for the first time. Rachel as a new non-executive and Tracy as one of our new associate non-executives, so warm welcome to them. And I believe, I'm looking round, but is Stephen with us today as well? Great, welcome Stephen. Yes, I can see you, there you are. Stephen, welcome as our new partner member and obviously as Managing Director of Worcester Acute. Okay, I think that's everybody to welcome today. We haven't had any apologies for absence, but a note that Jane Ives is currently not with us, so we'll hopefully see Jane joining us very soon. So I will move on with the rest of the business, but before I do, I just really wanted to recognise that, you know, it is the start of the new year, so happy new year to everyone, but also wanted to recognise that you know, this period of time is always a difficult period in health and care services, and I just want to thank all our staff and colleagues and partners who've worked tirelessly over this period, and particularly with recognising the challenges of industrial action. So just wanted to thank everyone and recognise the efforts that people will undoubtedly have gone through over this period, and you know, recognise the importance of the work that everybody does. So thank you very much. Okay, well, we move on. Are there any declarations of interest that we need to note in addition to our normal register? Sarah?
Thanks, Krishni. Just to declare an interest in item 11, the deep dive into stroke. As a trust, we obviously provide stroke rehabilitation services. Great, thank you, Sarah. That's helpful to note. And just double check, yes, there's no one else, so thank you, we'll note that. With regard to item 4, governance log and board forward plan, there are no actions outstanding that I could see. There is just one item that is not due, I think, until March, which is our return of our primary care access recovery plan, which we've already had once, but it is due back to us, I think, in March. Otherwise, Hannah, is there anything else that you wanted us to note?
I just wanted to flag, thank you, Krishni. I just wanted to flag that for next board meetings, deep dive, we'll actually be looking into the impact of industrial action on staff. So this links to your message at the start of the meeting. So I think this is really important to acknowledge that we will be sort of doing further work to acknowledge and report on the impact the industrial action has had.
Thank you very much, Hannah, and particularly with, I guess, a focus on well-being, because I think it's such an important priority for us in terms of the resilience of our services, really. So thank you, really helpful to note. Item 5 is the minutes of our previous meeting on the 15th of November. So can I check any points of accuracy first of all? And if everyone's content, we will approve the minutes. Everyone happy to sign those off? Excellent. Thank you very much. So note that those are approved. So we move on to our patient public voice section. We don't have any questions from the public today. If there are any members of the public watching, I do want to encourage people to use the facility on our website to submit any questions. We'll always welcome those. But we don't have any today to respond to. So we, without any further ado, move on to the patient story, and it's over to Kath, please.
Thank you, Chair, and good morning. The following story describes the experience of David and Maggie. These are not real names. These have been anonymised for anonymity. Apologies. Oops. Apologies. Oops. The patient experience highlights the importance of prevention, early recognition of stroke, and timely access to effective treatment in reducing premature and avoidable mortality and improving the quality of life of those impacted by strokes. This is especially important as stroke prevalence is forecast to increase by 15% over the next 10 years for this ICS. This story touches on thrombolysis, which is the ability to administer blood clot dissolving medication in a timely manner. David, a father of 2 young children who works as an office manager, had a stroke in early 2023, aged 47. David has type 2 diabetes. Maggie described him as a little over his BMI, but not excessively. David therefore had annual diabetes checks where blood pressure, cholesterol, blood glucose levels and other metrics would have been monitored. He had missed his annual health review due to his work pressures. Neither David or Maggie had realised the significance of the increased risk between diabetes and stroke. David was at work when he started to feel unwell. Work colleagues told Maggie that he initially thought that he was experiencing a migraine. David remembers very little about that day. Work colleagues called for an ambulance after they recognised he was displaying classic stroke-like symptoms of facial weakness and slurring of speech. National campaigns continue to highlight the significance of when stroke strikes, act fast, call 999. And just to put it here, face, uneven smile or face droop, arms, strength unequal, weaker if tries to raise, speech, slurring or words are unable to speak, time to call an ambulance. David was taken by ambulance to Worcester Royal Hospital on a pre-alert, so the hospital and stroke clinical nurse specialist would have been expecting him. He was quickly seen in A&E within an hour of the stroke onset, and tests confirmed he was suitable to have a thrombolytic drug to dissolve the blood clot that was causing the stroke symptoms. Following the thrombolytic injection, he was transferred to the stroke unit where he had further scans to monitor his progress. Despite the quick action of the emergency services in A&E, the stroke caused damage to David's speech and weakness to the right side of his body. Without thrombolysis, the impact of the stroke is likely to have been more extensive. David spent 2 weeks in hospital where he received regular physiotherapy and occupational therapy reviews. They took their time and explained what he needed to do to recover. The occupational therapist made sure everything was in place for a safe discharge home, and the physiotherapist advised on activities to keep David motivated and help lift his mood. So just a wee bit about community support and recovery. Upon discharge from the hospital acute stroke unit, David was supported by the community stroke service team of nurses, occupational therapists, physiotherapists and speech and language therapists. All were described as very professional and supportive. David's mood became very low when the impact on his and his family's life situation was realised. He became very agitated and upset. Maggie described, "I suppose he went through a period of grief for his and our old life. However, thanks to the staff and their support and positive attitude, he got past this and is more settled within himself. And he became determined to make as good a recovery as possible for himself and our family, and put his efforts into working hard at making the best recovery that he could." Maggie found the change to their life very overwhelming. This included competing demands of caring for 2 young daughters, increasing her work hours to full-time, and caring for David whilst dealing with his recovery and the realities of life such as financial demands. Suddenly, overnight, with no warning, you no longer have help from your partner, whom you shared responsibility with. Overnight, all the burden of day to day and the added pressure of losing the biggest household income and so forth really takes the toll. The family found the community stroke team were able to offer and signpost to a number of services who were able to support or offer advice during this difficult period with therapy and nursing support. David has learnt to speak with minimal hesitation again, walk independently and use his right hand functionally. He has returned to work, working from home with adaptations. He had an extended period of rehab to meet his needs, and David and Maggie were extremely grateful. Well, this is a positive story. There's a few learning points. David and Maggie didn't appear aware of the factors linking diabetes with the increased risk of stroke. He hadn't prioritised his last annual health check due to work pressures. Secondly, David was able to access timely treatment because his work colleagues recognised that he was having a stroke and called an ambulance. This emphasises the importance of public awareness and public health campaigns and messaging to support early recognition and response, in this case fast. David's stroke occurred in the usual working hours, but most people experience stroke symptoms between midnight and 6 AM, where the service response is more fragile and can vary. And I know Mary will be covering that in her deep dive later. Psychological needs often occur later. And we know that waiting lists for specialist neuropsychology are lengthy, and foundational levels of psychological support from neurotherapists can also involve long waiting lists, which obviously Mary will be dealing with later in the deep dive. And I rest the story there. Apologies for the little difficulties at the start, and we've got Mary here as well on the technical specialist to answer some of the questions as well. So thank you very much, Chair.
Thank you very much, Kath, and just really important that we're sort of as ever linking our patient story to the deep dive that we're doing later, so it gives us some really helpful context for the conversation we will have. But in the meantime, if there are any questions or anything that you want to raise at this stage, or we can bring them up when we have the deep dive conversation, happy to take anything immediately at the moment. Sarah?
I'll bring it up now because it's less healthcare related, which our deep dive is, but just really a sad story, but good to have it presented. I just wondered if there was a link, or we make a link between people's rights-based approach, so when people lose an income, what actually are people entitled to, and that link to the community and voluntary sector, who also provide services and may also know a lot more about the benefit system and what's available to people in that very short term. So do we have a good way of joining that up when someone's had the community stroke rehab? Thanks.
Thank you, Sarah. Is anyone able to illuminate a response on that? Nigel, your hand went up, but I don't know whether that was in relation to that. So shall I bring you in, and then I can see Mary wants to come in anyway. Nigel.
It wasn't directly to that, actually, Krishna. It was just an observation, and I think perhaps a bit of learning. The point I wanted to make was really about the recall of people with long-term conditions, and I think probably as a system there's something we could improve. I think this goes for perhaps hospital colleagues as well. When people do not attend appointments at hospital where they have a condition which is ongoing, and we realise actually the implications of not receiving further follow-up are significant, and I wonder whether we should be tying more into our PCN wellbeing teams to approach people and encourage them to engage with their ongoing long-term condition management, because sometimes it's not a life priority because life gets in the way, but actually I think there's an obligation on us to make sure that people are informed and supported in doing that, which may not be their top priority at that moment in time, but actually I think it's good for them and it's good for the system generally if we can improve our signposting into sort of well-being support.
And Nigel, that does sort of indirectly address sort of Sarah's point as well, because wellbeing support could be, I don't know, financial advice. It could be so varied, couldn't it? It could be all sorts of, access to other support. So being able to do that, I think, does sound very important. Mary.
Thank you, Chair. So, I mean, picks up a bit of what Nigel says. So, yeah, there is a very comprehensive rehabilitation and life after care, life after stroke care pathways. Always room for improvement, obviously, but it does deal with the financial aspects and does direct people to the right, to the services as soon as possible. And it often happens after leaving hospital as well. So, which sometimes patients and their families aren't ready to hear it, but they continue to pass that on. So, I've been interested in it myself, and I was very impressed with the support people get.
That's helpful. Thank you, Mary. Aman, please.
Thanks, Krishni. My question, I've been through something similar, but in the different systems, and my own experience was that there was very little support for the families, very little awareness of what the risks and stuff were. So I just wanted to understand, in our system, what do we do to help educate the families and support the families that perhaps are dealing with things like this?
Thank you, Aman. Mary, are you able to come back to that?
Thank you, Aman. I mean, a very pertinent point. I've seen family members go through this as well. It's very scary, isn't it? And it's very uncertain. I think we do, as I said before, I think we do very well on this. There is good link up between our acutes and community and life after care strokes, and particularly the life after stroke care. Particularly that service, because that deals with the carers mainly, and the financial aspects and the social aspects and trying to get psychological support. One of the things that we probably haven't got enough of, which I think is a national issue, is the psychological support to the individual and their families, because this is a life-changing event, isn't it, often? So the psychological support, which probably the teams are telling me it's probably about 6 months it really hits, what this means long term, and that psychological support is not in the amount that we need. So as part of the review of the whole stroke pathway, that's something we're looking at for the future.
Thank you very much, Mary, and thank you, Kath. I think we're clearly going to come back to some of these things, aren't we, Mary, as part of the paper later. So, but appreciate the context of the story, and thank you, Kath, for sharing that with us. So we move on to our strategic update section. Just a reminder, with all the items that are following on the agenda, really appreciate colleagues perhaps providing input over 5 minutes or so, and then allowing plenty of time for questions so that members can raise as many questions as they would like. So we start with Simon's report as Chief Executive. So over to you, Simon.
Thanks, Krishni. Good morning, everybody. Long report, and I won't spend time going through the detail, but just to draw out a couple of bits. Krishni mentioned at the start the range of changes to board membership, and the report covers all of those in some detail, and welcome to the people joining us for the first time today. I can take you then to page 5, just to pick up the various aspects of planning. So we're at that time of the year, as Krishni said at the start, where there are pretty significant operational pressures almost in every service, but at the same time attention has turned to April and the 24-25 financial year. There's a lot of work going on behind the scenes to try and get ready to get a plan together to work out budgets and financial allocations for the new year. Some of the national elements of that have yet to be received. We normally would get that prior to Christmas. We haven't had some of the national elements, but there's a lot of local work going on in advance of that, really. Just 2 more bits on page 5 worth pointing out. Real congratulations to Jane and Stephen's teams for their CQC maternity assessments that have both come back as good. That's really quite unusual and quite rare across the country. CQC are inspecting maternity services all over the country, and lots of systems and hospitals are struggling with that inspection, and they're finding issues. It's great that we've got 2 providers of maternity services, both on a real upward trajectory, and it's really good. Actually, the CQC has seen that and has noticed that, and that's evidenced in the report. More work to do, of course, there always is, but nice to be able to celebrate some success, actually, and well done to the teams involved in that. And similarly, the work that the Children's Commissioner is doing with Herefordshire Council, recognising that the council is on the right track with their improvement journey as well, is important. We talk a lot about regulation, don't we, in our board meetings. It's nice actually when some of the regulation recognises some of the good local work. And then finally, there's a lot of emergency planning information contained within both appendices of the report, and I'm obviously happy to take any questions on that or other issues. So Krishni, happy to go to questions.
Thank you, Simon. It is certainly a wide-ranging report covering a lot of information. So over to colleagues for questions or comments. David Whiteman, please.
Thanks, Krishni. Yeah, in relation to the emergency preparedness, Simon, there was a report in the HSJ on Monday, I think, that we as a system don't have a system-wide response plan in the case of a cyber attack. And I just wanted to give the opportunity to confirm whether that is the case, and if so, what the plan is for that, or whether in fact that report is incorrect and in fact we do have a system-wide plan.
Yeah, we have got a system-wide plan. I think we recognise there are some significant areas for improvement, and again, there is work going on to tighten our approach. Cyber attacks are one of those areas where you can be prepared today, and that's fine, but new threats emerge, don't they? So what you need assurance is that the preparedness is evolving as well to take into account the new threats. Cyber attack is a big risk, I think, to us and to all organisations, but particularly public sector organisations. There's a lot of work going on, David, to tighten our response and get our plan in even better shape. But we are very excited on that.
Thank you. Thanks, David, for the question. Mark, please.
Thank you, Krishni. Thank you for your report, Simon. Again, it's about emergency preparedness, and I'm aware over the last 12 months a huge amount of activity that's gone on within my own trust to meet what is some new standards, shall we say, which has caused difficulties through EPR. I wondered if anybody, yourself or anybody on the screen, could comment about our working together across the system in relation to this matter, rather than certainly the NHS providers and the ICB being within silos, because I'd like to think we're all sort of in this together, especially on this item. Can you comment or give some assurance around that, Simon?
Yeah, thanks, Mark. Really good question. And as we're aware, there's a lot of work going on looking at our back office functions and some of the expertise that we all have on our own. This area is probably top of the list where we feel there's the biggest and shortest term opportunity to share some expertise, to be more resilient when we are together, and to get more consistency. So there's a lot of, I would strongly suspect that over the coming months, a new model will emerge around this, where there is a single system approach actually to all of this. It's interesting the way NHS England approach it. They come through me as our emergency accountable officer and through the ICB team to have for assurance that the providers have all got the right arrangements in place. Clearly, it's much easier to provide that assurance if it's a single function and a single team. So that's where I would like us to get to really over the course of this year. And I'm quite confident that will be the position we end up in.
Thank you. Thanks, Simon. Thanks, Mark. Tracy, please.
Sorry, I just couldn't get the mouse to the mic button. I've got two questions, if I may, please, Simon. The first is around the Accelerating Reform Fund. Probably just because this is my first board, I just wondered if you could put some timelines around that. It just says the ICS is working through the lead authority Worcestershire, but it doesn't say the timelines, or if we've got a proposal that's already in place, or if they're still working that up.
Yeah, very happy to answer that one, Tracy. They, I think it's very much been led by the two local authorities, and the ICB is in a supportive mode with this one. But my understanding was we'll know by the 9th of February, I think, whether the funding has been awarded, and if so, all of those improvement programmes are ready to go. And obviously, with the Accelerating Reform Fund, the hope that it's an ongoing source of funding to pump prime some of this activity. So we'd hope. We're relatively optimistic, I think, of being successful with the bids that have gone in. and actually there is a further pipeline of ideas for next year and beyond as well. So it is something we're keen to support.
Okay, thank you. And then the other point was around the measles masterclass, and it sounded fabulous that there's obviously national and regional interest in that. I wondered what the policy, again, because I'm new to the board, what the policy is on entering these sorts of things for various awards and promoting them that way.
Yeah, I'll be honest, it's not something we have at the top of our list, is seeking validation through awards. I think the feeling, and we talk about this a lot, we know when we've done a reasonable job. We don't really need the validation of the Health Service Journal or someone to tell us, and it can be quite expensive and onerous to go through those processes. Having said that, that doesn't mean we wouldn't do it. I think we're just quite selective about the things that we put forward. It's interesting in this case, I do think this is quite innovative. And ironically, Jonathan Leach, who's a local GP who leads this for us, he was on Good Morning Britain yesterday morning, apparently, being interviewed about the work that we're doing. So again, great profile for us. And the masterclass happened yesterday, and I think he said to me last night there was 120 people dialed in, and it's been recorded as well. So a great example of the system coming together and sharing learning. Jonathan makes the point, and he's right, that lots of GPs that trained less than 30 years ago, they might never have seen a measles case, because obviously we've done very well as a society of managing measles. It's starting to reappear, so the ability to help clinicians understand the early signs, the best treatment options, it's a really good, healthy, constructive thing to do. I mean, we'll reflect on whether we spend the time putting it in for an award, but just so you know, that isn't something we have at the top of our list often to try and get that kind of recognition, although I recognise it can be important in some instances.
Thank you.
Thank you. And just, you know, clearly, Simon, for, you know, the fact that he appeared on television, I think reinforces that this is quite big news at the moment, isn't it? And although I think the data shows that, you know, the level of vaccination in Herefordshire and Worcestershire is positive, we do need to be mindful of making sure that all our communities have got sort of you know, sufficient protection. So I don't know whether we're looking at the data sort of below the system level to just understand whether there are any particular communities that we do need to focus on. Is that something we've given any thought to?
Yeah, we have, Krishna. Thanks for prompting me, really. So we also have the Your Health bus now as well, which is an important part of our arsenal when it comes to targeting intervention for particular communities, and this will be on their agenda. I mean, in terms of Herefordshire and Worcestershire, we've got very low and almost no measles at the moment, but we are very conscious. There have been quite a few cases in Birmingham and in Coventry and Warwickshire, so our bordering areas, and the logic suggests that will find its way into our counties as well. So yes, the masterclass was about raising awareness and almost trying to be prepared for that, but clearly we need to dig deeper into those communities with the lowest immunisation uptake and target first efforts there. And through the Your Health bus programme, for the first time, we've got that ability to do a more outreach and focused approach, and this is exactly the type of thing it's there for.
Great, thank you, Simon, and thank you very much, Tracy, for those questions. Vicky.
Thank you, Krishni. I just wanted to ask Simon, just on the GIRFT, because I think the patient-initiated follow-up, I know we've done work within this system, but I was just wondering whether they had any suggestions or have the nationally available patient information to back that up, because and also a key sort of target that they suggest for all of those pathways, because it's a lot of work across all pathways. So I just wondered, have we got a phased approach, and have nationally we got the patient information to align with that?
Yeah, thanks, Vicky. I mean, Mary, I don't know whether you want to come in, but we've done okay at the patient-initiated follow-ups. That's one of the good things in terms of our wider outpatient transformation programme. I do worry that we might hit a bit of a wall, though, and kind of have gone as far as we could have done with the things we've done so far. And clearly, as we move into next year and beyond, this will have to form part of our transformation programme for elective care. But Mary, what's the situation with the patient information element?
Yeah, so there has been national comms for patients. We've given a lot of feedback on it. We're not sure it hits the button, so it's being revised. I believe that was the latest I heard. On the PIFU overall, Simon's right, we have done well. I think it's important we engage the clinicians even more before we try and force this through, because to make it work, to have the benefits for the patients and the staff and the system, we've got to get the clinical engagement right. But we are getting good engagement across the system now, particularly from both acute trusts on this, and it's now starting to reap some benefits. So I think, but I think the target is going to go higher from what I hear for the next couple of years. So there'll be some challenge for us in that.
Thank you. Thank you. Paul Walker, please.
Yeah, thank you, Chair. Thanks, Simon, for the report, and thank you for maintaining the profile of children's services and improvements that are being made. That's good and helpful, and it's working well because we're doing more of that together. I think one of the change of dynamics this time has been a focus on the pace and change and the pace of delivering those improvements. And one of the things when we bring back our regular progress report to the board will be to focus on those specific 6 priorities which the Commissioner has asked us to work on, which focus on increasing the pace of change. But I did want to pick up on perhaps my favourite subject when it comes to these reports, Simon, is around dentistry in Hereford. And I was pleased to see the increase in capacity from April onwards that's coming forward. But I wonder whether there's anything I can do to support your work in the region in terms of allocation of funding into dentistry into Herefordshire, and if there is, only too pleased to play my part.
Yeah, Paul, you've walked right into one here as well, because there is something I need your help with actually. So we've got those 2 new dental contracts in Herefordshire. There is a bit of a local planning issue around change of use and planning restrictions for both of the new locations. So I had a note this morning from Charmaine asking me to pick up with you to see whether you could expedite some of the local planning issues, but I'll send you the detail of that a bit later. We're really keen to get those practices open. Just getting the premises sorted is the final hurdle. On your wider points, I mean, I think I'm pretty confident that we can get an appropriate allocation of funding over the coming months moving forwards. Because I've taken on this regional lead role, it has given me quite a privileged position and access to the people making those decisions. So I'm quite confident we can get, not maybe immediately, but certainly over 2 or 3 years, quite an increase in the allocation that we get. I think there's still a massive challenge then with spending that money, because as Mark will report later, one of the positive elements of our financial position is a significant underspend in the dental money that we've got. So we're not even spending the money that we've got, even though I am arguing that they should give us more. So we're going to need, as we've talked about before, a whole load of new creative different approaches to commissioning NHS dentistry. It's great that in Herefordshire, a couple of those new approaches where we've provided some additional incentives, they've come off. So again, that gives me confidence that with a flexible approach, we can do something. But in terms of getting the funding, let's let the NHS England process play out, and let's reflect then on whether we're happy with the outcome. But I'm quite confident we'll get a reasonable outcome from that. But you can help me with the planning, definitely.
I'll do all I can. Thanks, Simon.
Great, thank you. Yeah, it's a good step forward, I think, from where we were a year ago, or 18 months ago, where we were really quite concerned about how that was going. But obviously, a lot more work to do on the dental plan. Nigel, please.
Yeah, just a quick one on measles again. People will be aware that it's a very infectious disease. It's got an R number of 15, and the impact on staff is that it causes it necessitates a self-isolation period of 21 days. Now, so it's really important then that our staff vaccination rates are up. And I just wonder where we were with our staff vaccination rates and whether there's still work to be done.
Yeah, Nigel, if I'm on it, I don't think we even collect that information. So we obviously collect information on flu and COVID vaccinations because they are delivered now by us. The measles vaccinations for most of us were delivered in our childhood. I don't even think we have that level of information. We would be reliant on practices keeping that level of data locally. Will, do you have anything to add to that?
No, practices are now, it's actually come out this year, a requirement for practices to survey the staff and find out about their measles levels, and I'm presuming it's the same for trusts. So I'm not confident, but I'm pretty, yeah, it's certainly become a requirement for practices to find that information and store it and then see if they can get people vaccinated.
Thank you, Will. I think trusts, am I right? And Sarah Sarah or Stephen might be able to help with this, but I'm conscious that I think as part of occupational health screening, when you join a provider or NHS provider organisation, and Jane might be able to comment as well, but you might be asked what your vaccination history is and that sort of thing. So I don't know if there's any. I've certainly never, in a trust capacity, seen records of that or rates of that, but the information's probably been collected somewhere along the way. Sarah?
You've probably covered it, Krishni, but yeah, the occupational health definitely collected on all new staff and seek to offer immunisation as appropriate, but I don't see an actual figure on uptake as a provider as a consequence, because, as Simon says, some staff had their vaccines a very long time ago, but occupational health do hold that data, so we could certainly ask if it was possible to seek that.
That might be, yeah, it might be useful to understand, mightn't it? But it's just whether it's difficult to collect that data. Perhaps Katie, yes, Katie, do you want to comment?
I suspected that was going to happen, Krishni. Yeah, I will speak to the HR directors when I see them and see what's doable in terms of getting hold of that data, because I can absolutely see Nigel's point that if we see this as a risk coming along, it would be useful to understand and get ahead of it. I'll take an action on that.
Great, thanks, Katie. Thanks very much. Okay, a couple of just observations from me. I mean, there's a lot of content in there, and some of that feeds through to later reports as well. But I did particularly wanted to note, at least, because it was a very positive report on primary care access. I know we're going to be revisiting this topic in March, as we've said earlier, but the appointment levels in December were recorded as particularly high. So I just wanted to note that, because I know this has been an area of public concern and continues to be so, and it felt important to note that improvement. Simon, did you want to particularly comment on that?
Yeah, I was expecting somebody to ask me about that, to be honest, because it's so topical, and it almost every discussion we have locally, and I'm sure the health watchers would both confirm that it's a big patient issue. I mean, my reflection is, I mean, wow, 19% more appointments, that's fantastic, but actually we need to recognise demand has risen significantly as well. So even though we've got 19% more appointments, there still are a whole load of people that are saying they can't get the access they need. So there's a bit of reflection to me about just how quickly demand for GP appointments and access is. We can't assume that that's a steady growth. It seems to have been an exponential growth in demand that has to be matched by an exponential growth of capacity, but we're going to have to keep trying to keep up with that, aren't we? And I know, you know, we're in general election year. This is a big topical political issue. There's going to be a lot of discussion over the coming months about this. We need to keep moving forward, keep improving, but that relationship between massively increasing demand alongside appointment capacity is really, really important. So we won't be complacent. We also know that it's not consistent across every practice and every PCN. We do need to manage the variation. So, but I just think it's important we get the narrative right on this. I think I wouldn't want to be accused of, well, we're resting on our laurels just because we've got 19% more appointments. Nothing could be further from the truth. We really need to keep straining to increase capacity and to manage demand and both of those things are equally as important.
Thanks, Simon. That may well have prompted some more points or questions, so I'll bring people in on those. Tracy first, please.
Thank you. So it's the general practice activity data. So presumably this is on the back of investment into additional and diverse workforce in the GP community. So perhaps more nurse appointments and things and pharmacy appointments. Is that driving the growth, or are we seeing more GP appointments as well?
Yeah, I mean, almost all of the growth has been through the additional roles. So exactly as you describe, a whole team of new professionals who work in general practice who can meet people's needs without the need to record to a GP. You know, again, got to get the balance right between levels of GP capacity with additional roles, but that's been the national strategy and the local strategy over the last 3 or 4 years. Get those additional roles wrapped around general practice teams and use those to cope with some of the increased demand. And largely, I think that's a really good plan, really. We just need to, again, not be complacent, because there's always further steps we need to take to move that on.
But presumably the investment was attached to business cases that would have a shift left impact and a reduction on ED. So are those specific business cases that you've looked at, or is this?
I mean, mainly, Tracy, this was part of a national initiative. The additional roles reimbursement scheme was a national initiative where every practice in the country was offered additional funding to put additional roles in place. So we've got a whole range, and you'll pick this up in your time with us. There's a whole range of additional local initiatives that support that, but predominantly this is about take up of that national scheme. And again, I would argue that in Herefordshire and Worcestershire, take up of additional roles has probably been higher in lots of other areas, because of, you know, the fairly open mind and creative approach that Nigel, Nikki and colleagues take to GP access. But so yeah, the majority of that additionality is because of national initiatives, actually.
Okay, thank you.
Thank you very much. Sarah, I saw that you put your hand up, but your hand has disappeared. So I don't know whether that was technical or not.
No, thank you. It was just I think I put my hand down because Simon was given an answer. I think I just wanted to pull out that in the paper there's just a line without any value sort of or judgment attached to it, saying that we're third because of a high rate of GP appointments as opposed to additional roles appointments. My own perspective would have been that, you know, not to attach value to that and say that it's about seeing the right person for the condition that you've got. And actually, it's very good that we offer a lot of GP appointments, but equally, if that's not who you need to see, if you needed to see a physio or another, then clearly that's good. And I think you brought that through, so thank you. But I think there's a lot of politics attached around the additional roles, so I didn't want to go further, but it was more just that I guess it's a question really to Will or back to Simon, that we're not attaching judgment to seeing a GP over and above other people if that other person is right to meet the needs of your condition.
Yeah, indeed.
I mean, 1,000,000%, Sarah, absolutely. It's meeting need. And seeing a GP isn't the best way to meet a lot of need, as you know better than anybody. So yeah, 100%.
Yeah, I just come in on that. I think it is the whole point of this is about the vision for modern general practice is about patients calling a primary care, having ease of access, but actually having a rapid triage at the point of access, so they go to the person that's best there to meet their needs. Now, actually, if they've got a musculoskeletal problem, that is almost certainly a physiotherapist. This is not a GP. Physios are best qualified. Part of that, though, is about the patient's perception of thinking they want to see their GP, not fully understanding actually a physio is the better thing. So there's a whole bit about working on educating patients about actually how is this new system going to work, how it's looking. The practices that have established really, really good patient triage and direction and really helping their access to the patient satisfaction is improving. There is a little bit of transition there, and the hope is obviously as you improve patient aspect, that then improves access across the system, including into A&Es, but it's not a direct relationship as well. So I think we just need to be wary of that.
Thank you, Will. I mean, it is really important, isn't it, that if somebody needs a physiotherapist or physiotherapy, that actually, if the triage is done really well, why waste a GP appointment? to determine that, and then for the person to have a separate appointment with the physiotherapist, it doesn't really, from a patient point of view, it doesn't make sense either, I don't think. So so it's a really important recognition. And I think also similarly, we've said this before about online appointments as well, or virtual appointments, that it's all about sort of having a range of options, isn't it, rather than and that meet the needs of patients rather than a prescribed approach. Nigel.
Thanks. I think Will has actually made the point I was going to make initially, which was about those additional roles and the fact that with static or decreasing numbers of trained GPs and increasing demand, we have to rely on our colleagues to deliver a lot of appropriate services. And actually, some, you know, it's a change for a lot of our population. So that needs to be continued to be managed, and the messaging needs to be that actually it is appropriate to see some of our specialist colleagues who are more appropriate. And I think Will made that point very clearly. So I think that is going to be an ongoing thing. We have to just keep on with that messaging. And I just wanted to make a point to Tracy about, you know, what effect is this happening? What is the effect of on the hospital? So looking at our dashboards in Herefordshire through our enhanced care and care homes, as an example, where we're having integrated care, we're seeing a 1/3 reduction in A&E admission as a result of that. So this is really good example of integrated working, using our ARS roles with GP involvement, where in integrated teams working with community colleagues, we can have an impact on acute activity. So I think there is sort of emerging evidence there, and I think that's pretty good news.
Thank you, Nigel, and thank you everyone for the contributions on that discussion. As I said, we'll be returning to primary care access in our March board. I just have one other point, and it's a practical one. On top of page 5, well, we talk about best value care in the right setting, and that's all about our demand and capacity modelling and the sort of results of our point prevalence audits that we've now done over 2 years. There's reference, and this might be one that I can go straight to David on, or Hannah might want to say from a governance point of view, but there is a reference to a final report which will be used to inform strategic discussions that will be considered as part of the 24-25 planning process. So just wondered what the board's visibility of that is going to be. David, Simon, Hannah, whoever can comment on that. Are we going to see that just as part of the planning process, or is there something that you're planning to bring to us to give us an update on where we are really in terms of those findings? To you, David?
Yeah, sure, thanks. I'm going to be writing the report probably towards the end of this month and then through February. Or beginning part of February. There's quite a lot of data to crunch to get it all in the right position. I would anticipate the best way of bringing it to the board will be to include it as an appendix in Simon's report to the March board, or to include some of the detail in that process. And then if we want to have a more detailed discussion, maybe in one of the development sessions, we could pick it up there. But definitely bring it as an attachment in the March Chief Exec's report.
Great. Thank you very much. Thanks, David. So we'll note that as our planned action on that. And I think we agreed an action as well for Katie to follow up on the measles vaccination rate. So that concludes our discussion on the Chief Executive Officer's report. Thank you, Simon, for that, and for colleagues who've been involved in putting that together. The board is asked to note the content of this report, and particularly the emergency preparedness, resilience and response core standards position. And also noting the point that Simon raised at the beginning in response to Mark's question about sort of further bringing together of our focus on this and potentially kind of aligning our working together to improve really our overall response. So thank you very much for your questions and comments. We move on then to item number 9, which is the Board Assurance Framework Report. And just for a little bit of context, which I'm sure Hannah will add to, I think we thought it would be useful just to get to remind colleagues, and for some people this will be new, but we did agree probably nearly a year ago now, Hannah, I think, or perhaps 9 months ago, some strategic priorities for the ICB, and we thought it might be helpful to have a bit of a refresher on where we are against those. So over to you, Hannah.
Yep, thank you, Krishni. So yes, indeed, we did. The board did agree a set of objectives and priorities for 2023-24. I think that was back in May. The board assurance framework does capture all those priorities, so all the risks, controls, mitigations, assurances, all ultimately link back to those priorities. But I suppose we normally report the BAF very much through a risk lens. So this time we thought, given that we are 2 months away from year end, it would be really helpful to actually take a slightly different approach and do more of an in-depth analysis of where we are in terms of each of the deliverables. So the report is essentially in 2 parts. So the second part is the one that you would see normally in a board meeting. So that's the kind of BAF report stating any changes in assurances, any new risks that have been open and so on. But the first part really has been done as a priority by priority review. So we've got 6 priorities that have been agreed by the board. We took each one in turn and we had a look at what have really been the key highlights of progress and achievements over the last 10 months? What have been the main challenges, which are closely linked to our risks that we state within our board assurance framework? And therefore, what needs to remain our focus going into next year? So clearly next year, we will be looking at a set of priorities and objectives, but these residual actions we will need to kind of weave into those going forward. So then we have, in terms of the assurance rating, so we have moved over to the 4 levels of assurance, which I've reported on at the last board meeting. Normally we would be reporting on current assurance and target assurance, which is the assurance we're hoping to get to by year end. But again, we thought it would be really helpful to actually include projected assurance. So that's the realistic view. So, you know, the target assurance is the assurance where we would really like to get to by the end of the year. At the start of the year, we said this is really what we're aiming for. The projected assurance is where we feel realistically we're actually going to sort of land by the end of March. So what I would say is it's really pleasing to see that actually a huge amount of progress has been made in every single priority. Clearly, there are some limitations and challenges. I mean, where progress has been more limited, which particularly relates to objective 1 and 4, and 2, I suppose, to a degree in terms of finance. Those challenges have been well documented through our risk register, through conversations at programme boards, subcommittees, committees, and indeed at public board meetings. Some of it covered by Sam's report, some will be covered further today by the reports that are still to come. So I'm not going to kind of go through it priority by priority, but I'm very happy to take any questions in relation to any of it, and I'm sure colleagues will help me because this report really does spin the whole work of the ICB. So some of it I might need a little bit of help with, but happy to take any questions.
Thank you, Hannah. Vicky, please.
Thank you, Hannah. I mean, this is a great format, isn't it, to provide that overview of progress as well as the challenges. But I guess I just wondered whether we're clearer after having this in place for a year now about what actions would really help shift the dial on the risk score against the delivery of the objective, and whether when you've collectively worked on this, there's an idea about how we might enhance this going forward.
Always really difficult, Vicky, isn't it? I mean, every risk is being looked at from that point of view. So every time we do a risk review, and that now happens at programme board level, so a kind of true system ownership, we always look at what is the thing that we haven't done that could kind of take us a little bit further. It's not always straightforward, but all I could say, I suppose, and it's got a general statement, there is a real in-depth review of every risk and every deliverable pretty much monthly. So, you know, some of those mitigations might not be immediately obvious, but certainly the work is being undertaken to try to identify those as much as possible. And I'm sure if you have any specific question with regards to a specific risk that you feel hasn't shifted or hasn't moved, I'm sure the relevant lead would be happy to comment. But yeah, as a general principle, I think the risk, what I'm really pleased about is that we are really developing a risk-aware culture. And I think we are, you know, this is not just an add-on that we kind of do when, you know, 10 minutes before we kind of need to submit board papers. It really is weaved into every layer of our governance, and I know programme boards do actively review their risks as part of their meetings.
Thank you, Hannah.
Thank you. Sarah, please.
Thank you. It was just a question about one of the key risk updates. Bottom of page 12 talks about pharmacy workforce fragility, and that's quite alarming because it talks about a I think it's 18% reduction in pharmacy headcount. I presume that number is related to employed pharmacy staff within the system, but I wasn't sure if it also related to community pharmacy teams. So I was just interested if anybody knew any more about that, particularly given all the work we're doing around fuller and integrated care and how critical pharmacists are to the integrated care agenda. So I'm just interested to know a bit more about that, please.
I think we'll all...
Sorry, Hannah, go on.
No, I was going to say, well, Katie can probably comment.
I mean, I can't come in. We have shortages, I think it's fair to say, of pharmacy staff across both employed within trusts and general practice, but also in the community setting. I think that figure relates to the employed though. However, the problem we know does go out into community setting too, so it's a difficult environment, full stop. We have run the STAR workshop and we're doing quite a lot of work around looking at recruitment, but also training opportunities and how we grow our own piece. And there's also a little bit there about how do we look at how we use other people better, such as pharmacy techs and things like that. But it relates in, and actually relates into the other couple of medicines risks there, because actually that overlaps into how we provide aseptic services, and also the provision of things like the wholesale dealer's license as well. So it kind of overlaps into an awful lot of other aspects.
Thank you, Will. Katie, did you want to add anything to that?
I think Will's pretty much covered what I would say. All I would add is we do have a dedicated workforce planner on pharmacy because of this risk, and there's a lot of plans and activity going on around that, and rotation between community and trust is one of the things that they're particularly looking at, because we want to knit that together more closely, because we recognise the risk is that those in trusts may join community pharmacies. So I think it's well understood, and we've got somebody very dedicated looking at it, which is really good.
Thank you, and thank you, Sarah, for the question, because you know, clearly as part of our you know, sort of all of our activity around that, you know, I suppose diverting people to the right type of resource and access points for getting advice about their care. One of the things we've been promoting actively is sort of going to your local pharmacist for advice, that sort of thing. So clearly, you know, any concerns about sort of resilience of our pharmacies is going to be a concern. So important to note the context there, I think. So really good. The other risk that I just wanted, so first of all, thank you, Hannah, for the update. Really helpful to get that sense of where we are. And whilst, you know, there's you know, a lot of work still to do, there are progress in some areas which we've seen, and some specific activities which I think we've been able to move forward, which is always good to see. The thing that I wanted to pick up, which I could see actually from minutes and escalation report as well, that this had been discussed elsewhere, was this PIDMAS, the patient initiated digital mutual aid system, which seems to have been discussed in a number of forums, and there was some concerns about the potential risk of widening inequalities in relation to that. But the particular thing I wanted to pick up was implementing this seems to be taking a lot of our capacity without additional resource. And I do feel it's important for us to identify, because what resource usage these sort of initiatives have, because I think one of the things that I'm conscious of is, you know, one of the pressures on all ICBs and all providers is very much on workforce and workforce growth without corresponding you know, resources to match, I suppose, financial resources.
I think any sense, what I'm slightly concerned about is some of this is driven by national and regional initiatives that we're being asked to implement, but actually we haven't got corresponding resource to do. So I do think there is that may be a slightly controversial thing to say, but I do think it's important for us to recognise where there are things we're being asked to do which are important nationally and which we'll obviously take forward. The costs of that need to be understood, so we're really, really clear in our deficit to drivers, what the impacts of that are. Simon.
I would just agree with you. You know, Christine, we don't moan about this stuff, we just get on with it, but it is a good opportunity to point out the significant resource implications that often come with initiatives like this. I mean, Mary will tell you there is a small team of people trying to work on transforming elective care and delivering the various varied and significant performance targets in this area. On the whole, I think we've done really well over the last 12 to 18 months, and really quite proud of the work we've done. This type of initiative, though, that does come straight from a national team, it lands here. We're the system coordinators. We do our very best, but there are opportunity costs to putting resources into this as opposed to other areas of elective care transformation, for instance. We'll always try and find the right balance, but I do think it's a good opportunity to be realistic about the resource implications. Of course, as well, it comes at the same time, we're reducing our running costs by 30%, so we've got less people. We just have to get better and better and better at prioritising what the people we have, what they do with their time. And unfortunately, often national initiatives do take precedence. This is a great example of where we've just had to roll our sleeves up and get stuck in, but it isn't an unlimited resource, and it does come with a cost of other things we might want to do instead.
Yeah. Thank you, Simon. And I think we do just need to be alerting our, we have vehicles to alert national and regional colleagues about some of the impacts of these things. So I do think we need to use them, but I just wanted to highlight that because I think it is an important point for us to recognise. So thank you very much for the report, Hannah. We're asked as a board to just receive and gain assurance in respect of the BAF as usual, but on this occasion incorporating our objectives and an update on those as well as the risks in the normal way. And clearly what it also does is sort of cite potential areas of focus that need to be carried forward into next year, which will feature in our priorities for 24-25. So thank you very much for that report, and we note that as a board. We move on then to the committee escalation report, please, which is item number 10. And before I perhaps initially bring Hannah in, but then perhaps ask chairs if they want to signal anything particularly they wanted to bring to the attention of the board. Perhaps they could raise their hands as well. But before I start, I just wanted to thank Graham Hutchins, who moved on from us at the end of December. Graham was our audit chair, now ably replaced by Aman, who has been our associate for a while, but who's picked that role up. But Graham was not just audit chair for the ICB for that period of time, but also previously for the CCG. So I wanted to thank him for his service and his contribution to the establishment of the ICB before, whilst we had an opportunity to do that. Okay, over to you, Hannah, if you wanted to open this item.
Yes, thank you. So as well as the traditional committee escalation report, I just wanted to flag some committee changes and updates that we are in the process of making. So these are driven by several factors. So clearly we've got new non-executive members who we've introduced at the start of the meeting. So we are working, incorporating them into our various committees. We've also, from the 1st of January, have got changes to public sector regulation legislation, which has got an implication for our governance. in several ways, but in terms of committees, is we need to achieve a complete separation of duties between audit committee and any commissioning decision-making committee. So we need to have separate membership for audit committee and any other committees that make commissioning decisions. So that has driven some of our committee changes. We are also in the process of formally establishing a system finance committee, so a joint committee across the system. So this is a committee that the current finance forum will transform into. And finally, there is a refresh of the joint mental health commissioning committee. So all those kind of aspects have led to some committee membership changes and will also influence changes to our committee terms of reference. So over the next few months, couple of months really, we'll be reviewing all our committees from effectiveness point of view, and that will then result in updated terms of reference, which will be brought to this board in March for approval. So the specific committee changes are noted on the second page of the report under section 4, but other than that, it's back to the chairs for the usual escalation and update. Thank you.
Thank you very much, Hannah. Any of our committee chairs wish to comment on any aspects of their report? Very happy to take the report as read, of course, but if you did want to highlight anything, you are most welcome to do so. Pause a moment just to give everyone a chance, but no, everyone seems very content just for us to move on. So I'm very happy to just note the committee update then and the key decisions and items of discussion. I think the AAA methodology does really bring to the board's attention the key issues, and in fact, you know, some of that is obviously reflected then in the papers, the other papers that also we have been looking at already. The suite of committee minutes are also available and associated with the report in the interests of transparency and our obligation as a board really to gain assurance that our committees are discharging their responsibilities effectively. So thank you very much, Hannah, for that report, and to committee chairs for the work they're doing within their committees. Now, I'm looking at the time and I'm thinking that we might want to, we're somewhat ahead of time, which is not a bad place to be, but I'm thinking that we will take our break now and then we could move into the deep dive on stroke. So if we can give ourselves a 10-minute break and come back at 10:50, ready to start. And can I just remind everybody that this is being transmitted live, so I would just encourage you to turn your camera and your microphone off, and see you shortly to start at 10:50, please. Thank you.